Dr. Nikolay Peev from Kingsbridge Hospital, private hospital, to tell us about Ollif. Thank you, Nikolay.
Is Nikolay here? Yeah. Good.
I'm here. Hello.
Good to see you, Nikolay.
Can you see me?
Yeah. Yeah.
Hello. Nice
Hi.
meeting everybody. Hi, Salman. Hi, everybody. So, do you want me to share my presentation?
Please.
Okay. Just give me 1 second. Right. Okay. Share presentation. Right. Okay. So, do you see it?
Yes.
Okay. Right. Okay. So I'll try to be also on time. Thank you so much for providing me with this great opportunity to be part of the Young Neurosurgeon Virtual Conference. I'm going to speak to you about some endoscopic approaches, and in particular, one of them. But before that, I wanted to show you this is the last AO nomenclature about treating the different endoscopic surgeries and approaches. You can see that there are quite many now already. This is constantly developing. So it's shaping nearly as a separate subspecialty now. So before I continue, I'm going to talk to you about one of the LIFs, lumbar interbody fusion surgeries. So a couple of words. Over the last year since I started, I have done big number of minimal invasive TLIFs. I do about 500-600 injections per year, which is helping me to understand the anatomy and to understand trajectories. We're gonna get there as well. And also to start, what I'm going to present to you, very helpful was that I had previous endoscopic experience, cranial and spinal, and also my uniportal endoscopic experience since 2018. So all these minimal invasive techniques are quite demanding, and we always talk about a steep learning curve. So I'm going to start with what is steep learning curve. So basically, the learning curve is steep because every time you have to jump to the next level, you have to double your cases. So we have a good research from Paulo Pereira and group that is demonstrating that you need at least 50 cases to get at about 90% milestone of a minimal invasive approach. But then the learning curve is steep because from 90 to 100%, you need another 50 cases. So 100 cases to get 100% milestone. But you really, to call yourself expert, to understand what really is happening and to master the technique, you need about 200 cases. So there is all different types of lifts, lumbar interbody fusion. So you can see on that diagram. So I'm going to talk in particular about that transcambin fusion surgery. So I'm going to touch on transforaminal because transforaminal is basically the first step of the transcambin fusion. So you go transforaminal, you don't touch the, so I just want to make clear because many people don't actually understand that. We push the cage when we are doing that surgery through the foramen, through the neuroforamen. We don't touch the bone. We don't do bony work. And that has a lot of benefits. So this is the trajectory again that I'm going to talk to you about. So this is where we are going. This is the transforaminal approach. This is that. So we are exploring that tiny space here to make it big enough to push 10 millimeter cage that is 10 millimeter wide and 34 millimeter long cage. And this is again trajectory. This is not. This is obviously a model, as you can see here, one of the upsurgeon models. Obviously, because everything is percutaneous, I cannot show you intraoperative pictures like that because simply we don't skeletonize the bones like this. But this is the trajectory we're using. This is the inferior, superior articulating facet of the inferior vertebra. inferior articulating facet of the superior vertebra. This is the nerve root, as you can see here, and we are going just under the inferior the superior articulating facet, SAP, and we try to get inside the foramen in a perpendicular fashion to the nerve. Why is that? Because if you cross something in a perpendicular way, the crossing distance is the smallest, and like that, less chance to damage it. So we're gonna get to that a bit later, but I just wanted to make sure you understand what we are doing. We are going through that tiny space here, and we're doing lumbar interbody fusion surgery, and this is how you should imagine in the real situation. So let me play that video to demonstrate one of the cases. I'll start with that, and I will provide some explanations. This is a 49-year-old person that is previously very active, running marathons, also professionally very active. Unfortunately, she had to drop a lot of activities because of that grade 1 spondylolisthesis, as you can see here. That is causing severe radicular and back pain. And she came to see me, and then we discussed, and I have done this so-called intralift, endolift, OLL lift. So unfortunately, that procedure is still relatively new and doesn't have a set name. People are calling it different names, so I will just continue with transcambin approach. So this is a patient that had about 1 hour surgery. The hospital stay was less than 1 day, so less than 24 hours. So it was a day surgery, and the patient had a fixation. It was all done in a transcambin approach, everything percutaneous. As you can see here, I am in the disc. Initially, you introduce a needle, then you introduce different dilators to develop the space and the disc, and then you have plenty of instruments to do discectomy and to prepare the end plates so you can promote the fusion. And then finally, here you can see I am deploying the cage and expanding the cage. I am using expandable cage, and this is, you're gonna see shortly the final pictures. Very elegant and very minimal invasive, probably as minimal invasive as you can get for a interbody fusion surgery. So if you haven't, it is worth considering to start that in your practice. So it's a demanding technique. As I mentioned, steep learning curve. You need about 200 cases to call yourself master. Screw precision is always a problem, but that's not going to be the topic of the current presentation. Nerve at risk. Yeah, I'm going to discuss about that. Neuromonitoring or not. We're going to touch on this as well. Fusion rates and radiation exposure. So this is the normal pathology that is still, unfortunately, a mainstream of your training. So as a young neurosurgeon, probably you're still receiving training that is focusing in that area mainly. If you are treating one of the common surgeries that you start with when you're training when you do a spinal training, you will start with lumbar decompression, lumbar discectomies, and this is where the pathology is mostly located. And this is the bony work that you would be doing most of the time. So in order to, and this is the area, as you can see, that you can cover with this bony work. If you would like to consider endoscopic approaches, one of the main approaches that you have to learn, one of the first approaches is a transforaminal approach. And this is where the transforaminal approach is focusing. So you have to go on the other side of the facet. And this is the area that you can cover. This is the trajectory that you have to go with. So it's completely different trajectory. You have to go from the other side of the facet, and that's giving you a different perspective, and you need to learn a different anatomy here because of that, although it's very close. And so you are going through the Cambin's triangle, but not even the whole Cambin's triangle. So you are addressing the lower part of the Cambin's triangle most of the times. So this is one of the most important slides that I have in my presentation, and that's one of the most important messages that I wanna pass to you today. So transforaminal approach always starts with docking your instrument. Usually that will be a needle that you will dock on at the base of the superior articulating process of the lower vertebra. So then you can slide that instrument inside the foramen, and then you slide dilator after dilator to push the nerve laterally. And also sometimes you have to, if you do fusion, you have to go inside the disc and start expanding the disc as well. And like that, you are creating the space that you need to do all the work that you have to do. So in that respect, I always like to pass that message. Lower end plate is your best friend. So everything that you do, you have to do as close as possible to the lower end plate because of that situation here. You can see that because of the obliquity, the oblique passage of the exiting nerve root, you have to do everything towards the lower end plate, because if you do closer to the upper end plate, you're facing that situation. Upper end plate, you start docking instrument right on the nerve. Lower end plate, you go inside that foramen here, inside that small triangle, and so the nerve will be staying laterally. So this is why your lower end plate is your best friend. So anything you do, a lower end plate. Another thing that I have to stress when you're starting the that approach or any endoscopic approach, you have to have very good understanding of the X-ray anatomy, and this is like that because you don't have the normal anatomical landmarks with like with the open surgery. Everything is on X-ray, so you have a tiny approach that you have to do everything, and you push big instruments through that. So you have to have very good understanding of the X-ray anatomy, and even more importantly, you have to have a very good understanding how to make your radiographer to give you reliable pictures, reliable X-rays. So reliable X-ray is true AP image and true lateral image. So true AP image, a few important parameters that you have to chase for every X-ray that your radiographer is giving you. So your midline structures have to be right in the middle, means that the distance between the two pedicles have to be roughly equal. And also the end plate of interest has to be in the center of your screen, and it has to be aligned, not elliptical. So if you get that, then you're reliable and you have reliable information and you can proceed further. If that's not the case, then you may think that you're at certain object, but you can be somewhere completely different. So you have to be very careful with that. Same thing with the lateral X-ray, the object of interest line, but not elliptical. Make sure that you always demand that. That's very important. So the other thing that is very important for you to understand is the biplanar awareness that you have to have, and also the three-dimensional orientation, and also the trajectory. So if you go to the courses that start teaching you on transforaminal approach, they always start telling you how to dock your instrument, where to start, where you have to put your incision. So they usually tell you L5, S1, 12, 16 centimeter offset from the midline, L4, L5, 11, 14, etc., etc. But it's very difficult to imagine that somebody who is 60 kilograms and somebody who is 120 kilograms will have one and the same distance from the midline. So that's why over the years, as I was doing these approaches, I tried to develop a system or rely on a system that is not based on measuring centimeters, but seeing still some landmarks. So for me, landmarks on lateral X-ray is the supraspinous line and then the suprafascital line. So everything that's in between is green. It's green because on lateral, if you dock your instrument somewhere here in that green area, you're normally okay, and you will get inside the foramen safely. Obviously, if you keep if you keep the rules that we have set earlier. So this is on, this is the same thing on axial cut. You can see that this is the green area and the red area. If you go in the red area, means if you're too low, you may get inside the abdomen, so you may cause damage to abdominal organ. If you go in the blue area, you might be too steep, and you might not be possible to get inside the foramen or even inside the disc in certain occasions in appropriate angle. So you have to stay in the green zone. If you want to go in the disc and do lumbar interbody fusion, you have to go obviously closer, more steep, close to the blue line, but not too steep. If you would like to go inside the foramen, let's say if you are addressing, let's say, paramedian disc, you have to go very close to the red zone, but try not to go so much in the red zone. This is the type of preoperative planning that I do. Normally, I will put X on lateral X-ray, where the center of the disc of interest is on lateral. And then I'll put another X where the center of the disc of interest is on AP. And then if you measure the distance between the two points, this is somewhere here. This is somewhere in the middle. And then obviously, if you would like to go more medially in the foramen, you have to go down. Or if you want to go more laterally, you have to go more towards the blue zone. And that additional line that I have here is a line that is putting you in a direction that is perpendicular to the nerve root. That's what I mentioned to you before. So when I put the center here, I go slightly up to match that line that is built so it goes below the contralateral pedicle and above the ipsilateral pedicle. So contralateral pedicle, ipsilateral pedicle. That's how you build that line.
Excuse me, Prof.
And then the rest is 3D awareness. So you start with a needle usually that you start from that point on the skin, and you start progressing your needle until you dock the needle at the superior articulating foramen initially, and then go inside the superior articulating process, and then go foramen. And these are the two lines that you have to follow: posterior vertebral line and medial pedicular line. So when you are in the foramen, you should be not medial to the medial pedicular line, and usually not further than the posterior vertebral line. And that is to ascertain that you are already inside the foramen safely, but you're not inside the dura. This is the situation that you have to face.
Hi, Nikolay.
This is the safe situation. So you are in the foramen, but you're outside the dura. This is a good situation in case you would like to go into the surgery. For example, you are inside, you are lateral to the medial pedicular line, but you're here already in the disc, which is favorable in case you would like to do lumbar interbody surgery. This is not a good situation. Here you're in a posterior vertebral line, but here you're too much inside. That means that you're inside the dura. So if you are like that with your needle, you have just done lumbar puncture with a needle, nothing bad. So, but if you don't appreciate that situation, and if you start treading the dilators and you start dilating over that key wire and then needle, you might have a problem, because you will damage the nerves and you will create a lot of issues for you and for your patient.
Sorry,
So,
Nikolay. Sorry.
For the dilators, so as
Professor
I said,
Peev.
after the needle, you have dilators, and then you put the working cannula, and then you continue working. Couple of words about the foramen and the indirect decompression. All that technique that I'm describing, if you're doing lumbar interbody fusion, is relying on indirect decompression. And that is, I think, underappreciated and very potent technique. And the reason and my rationale behind that is that the foramen is a cylinder. And this is how we calculate the volume of cylinder. If you increase that volume of the cylinder, even with a couple of millimeters, the radius of that cylinder, which happens when you're doing direct decompression, you are basically increasing the volume significantly, and that's creating a lot of space. Promoting the fusion, you don't have anything else, so you have to put some bone promoter inside the disc. I use tricalcium phosphate, which I pre and post fill. Sometimes some of the back filling is going back.
Are you sharing this, please?
Yes, I'm wrapping up. I think that was the approach. Thank you so much for the opportunity.